Officer of the New Zealand. I'm the National Executive Officer of the New Zealand Down Syndrome Association, and I'd just like to introduce you to Sarah as well. So Sarah, do you want to say a few words?
Kia ora. I'm very happy to be helping Zandra out with this. I'm Sarah. I'm the CEO of the UpsideDowns Education Trust. We provide funding for children with Down syndrome to receive speech and language therapy, as the vast majority of you know from experience. But if you don't know about us, go to upsidedowns.co.nz to find out more information. And I did want to give a quick heads up as well that Zandra and I are joining forces again on Tuesday evening with speech therapist Fiona Kenworthy to provide a free SLT webinar with a question and answer session as well, fairly similar to this, slightly different format, but pretty close. And that's at 7 p.m. on Tuesday night, if you don't already know about that. And that one you have to register for. So again, jump on our website to do that.
Thank you. And then while you're doing thank you, Sarah. And then just to add in, just so that everyone knows, on a Friday night at 5 o'clock, well, through level 4 and level 3, we're going to do online events for everyone in our community, and other people are welcome to join as well. So 5 o'clock on a Friday, we have cocktail evening. On a Monday evening, at 7, it's for self-advocates, people with Down syndrome, to join us, and we're having a session then. And then on a Tuesday at 3 o'clock, we're meeting with families with younger children. So this week we're having a teddy bear picnic. Anybody to bring along your favorite plush toy, and every week we'll change the theme. So the links will be on our website. They'll also be on our Facebook page, and the links that you use will be the same links all the time. And depending on what comes out of the session this week, if there's a need, we'll run another session on the vaccine next Sunday at the same time. So enough from me. I just want to, Kim won't know that I'm about to do it, so I just thought I would introduce you to our national president. If you could just unmute and just say hi, Kim.
Unmute. Okay, hi everybody. Yeah, Kim Porthouse. I live in Otaki, and I've been president of the NZDSA for 3 years now. Just about to start my second term, so looking forward to that. and looking forward to this session. I think we'll all agree, probably, hopefully, that vaccination is really important at this time, and we'll get lots of really useful information from this session.
Sorry, I just had one thing that I forgot to say, just a little housekeeping thing. I'm sure it's not going to be a problem with this group, but we do expect, obviously, for everyone to be civil and polite. I have a remove button power, and I'm not afraid to use it. Just a heads up, but I'm sure we'll all be awesome.
That's great. Thank you, Sarah. And just quickly, I'll just do a shout out to 2 of the National Committee members. There's Bridie. She wants to say hi, and Bridie's from our Wellington zone, and Bev has just joined us from Whangarei. So I don't know, Bev, do you just want to wave so everyone can see you?
She can mute it, but I haven't got the volume. I can't get.
Cool. So there's Bev. You just heard her speak. So thank you, everyone. I'd just like to just introduce our 3 speakers, and just to thank them all. There's Rosemary, and there's Marguerite, and there's Geraldine, but I'll let them introduce themselves. I'll hand over to you, Rosemary, but just to say thank you so much for joining us this evening.
Thank you, Zandra. Kia ora, everyone. Lovely to see you all. I'm very impressed by the turnout, given it was pretty short notice that we organised this. So my name is Rosemary Marks. I am a retired, and I emphasise retired, developmental paediatrician. I'm not quite sure how I found time to work. The other thing which you may be interested to know is that I am leading a group who are reviewing and revising the Down syndrome clinical guidance document that's on the Ministry of Health website. And we hope it's going to be much improved when it finally emerges from our deliberations. So thank you. I'd like to hand over to my colleague, Marguerite.
Thank you, Rosemary. So I'm Marguerite Dalton. I'm still practicing as a developmental pediatrician. I work mostly in counties Manukau, but also a day a week at Starship, which is where I worked with Rosie, and we miss her. And I also work for the Immunisation Advisory Centre, largely in their well child area, but also giving advice to their 0800 line for vaccination queries. So that's how I've got roped in today. And now I'm going to hand over to Geraldine.
Hi everybody, my name's Geraldine Whatnell. I'm from Palmerston North and I am a nurse practitioner. My scope of practice is in intellectual disabilities with mental health. I've been a disability nurse for 40 years in a few months' time. I'm quite involved with the New Zealand Down Syndrome Association in a variety of ways. I presume probably my main connection there is I've got a brother who has Down syndrome. Back to you, Rosemary.
Kia ora, Geraldine, and Geraldine is also a member of our work stream working now on the guidance. So I'm just going to share my screen now, and hopefully this will all work, and I'll share the right screen. You won't get to see anything you shouldn't. So Marguerite and I spoke to a NGO DIAS service in Auckland a few weeks ago at their request on vaccination information for people with disabilities. Now, are you going to advance slides? Right. This is our disclaimer. We are here to try and answer your questions. We don't have all the answers. In fact, I don't think anybody has all the answers. We know there are questions that are worrying many people about access to vaccination, and we won't be able to answer all those questions, although since we first gave this talk, some of those questions have been answered. And we're not here to judge anyone. I think that's really important for you all to understand. So this is the summary of what I'm going to talk about. I'm going to talk about what a pandemic is. I'm going to talk about what COVID-19 is, about the vaccination, and about consent. Now, one of the reasons I've done it in this way is because I have discovered that even people who I think I would have expected to understand a lot of the science have sometimes been a bit hazy. And I'll come on to that in a moment. So what's a pandemic? So there are 4 words that we use. One is endemic. So that's a disease that's usually present in a particular geographical area. So, and it's always there, like dengue fever in the Pacific Islands. Now, an outbreak is when you get a local increase in that disease. And we've heard a lot about outbreaks over the last couple of weeks. So for instance, in the Pacific, when there is heavy rain and the conditions are good for mosquitoes to multiply, then the rate of dengue goes up and they get an outbreak. When it's relatively dry, they don't. So an epidemic is when the level of a disease is much more than we expect. And a pandemic is when there is widespread disease affecting many countries. So there've been a number of pandemics in history, dating back to the time of the Romans, which, and I guess, I'm sure there may have been pandemics before that, but there were fewer people and less travel. So the Antonine plague went on for, as you can see, 25 years. And that was probably smallpox, but we don't quite sure. Then there was the Black Death, bubonic plague. 200 million people died in the Black Death over quite a long period, over 100 years. But the population of the world was only about 400 million at that time. So it was a very significant pandemic. Then some of you will have heard older relatives talk about the Spanish flu in 1918, 1919. And 9,000 people died in late 1918 over a period of 6 weeks in New Zealand. And the picture here is the Public Health Department treatment of influenza, which I'm not quite sure how they were treating it, but that's from Christchurch in December 1918. More recently, we've had the HIV/AIDS epidemic, and that's still going, and there've already been about 30 million deaths. SARS in 2002, you probably recall, 770 deaths, quite contained. Then we had swine flu, and now we've got COVID-19. And as of this morning, 4.5 million deaths worldwide and 216 million cases. Now, I believe both of those are a significant underestimate because the data from developed countries is pretty good. The data from some developing countries is not so good. And, you know, I'm quite sure that in India, which is currently one of the most affected countries, there are small villages where nobody knows how many cases there are. So now a bit of basic biology, just to get us started on what COVID-19 is. So cells are the tiny building blocks which make us all up. You know, basically, we're not much different from an amoeba, except there's lots more cells in each of us. So what's in a cell? This is important. The nucleus contains the plan, the genetic code, the DNA, for everything that that organism needs to do. The mitochondria provide the power. Here we have the mitochondria. And the cytoplasm has other bits and pieces, including something we call organelles, which can make proteins. And that's really important when we start thinking about immunity. And then we have the cell membrane, which holds the cell together. So that's like the cell's skin. So what's a virus? Well, a virus is really just a tiny little box which contains the genetic code to make copies of itself. It's not a cell because it can't function by itself. It's not a bacteria like the bugs that cause illnesses like food poisoning and TB. And this is really the key message. It can only multiply when it is inside a cell of a living organism. When the virus isn't infecting somebody, it can't do anything. We might talk about that a bit later. Whoops, Daisy, what happened there? Press the wrong button. So what's coronavirus? Well, coronavirus is a virus particle, that little box, and its plan, its genetic code is made of something called RNA, a little bit different from DNA. That's what directly makes proteins. It's one of a group of viruses, which is called the coronavirus, and it's named for and this is coronavirus, and these spikes look like a crown, maybe, and so that's why it's called that. There are lots of viruses in this family. And the SARS-CoV-2 virus, so this is severe acute respiratory syndrome, coronavirus Mark 2 virus particle. Now, you'll remember I talked a minute or two ago about SARS-1. My own personal view is that if we had gone on calling this SARS, people might have taken it more seriously, but the decision was made by WHO to call this COVID-19. It measures 50 to 140 nanometers. Now that's incredibly small. So that is about 3,000 times smaller than a grain of salt. And you know how hard it might be to see a grain of salt on your kitchen bench if somebody spilt the salt. I'm now going to talk a bit about vaccine history. So think back to that slide about pandemics, the Antonine plague that killed all those Romans. Smallpox continued to be a big problem for several centuries until Edward Jenner came along. Now, Edward Jenner was a country GP in the west of England, in Gloucestershire, quite close to where I went to university. And he noticed that the milkmaids who worked with the cows did not catch smallpox. And so he drew the conclusion that people who had smallpox had immunity, he didn't probably use that word, to people who work with cows had caught cowpox and they had immunity to smallpox. So he tried using the fluid from the cowpox blisters to vaccinate people. And he showed that they did not get smallpox when they had been vaccinated. And the word vaccinate comes from the Latin vacca, a cow, because they were using fluid from cows. There was quite a lot of controversy at the time, and I won't go into that, but people were quite upset about being given fluid from cows. But anyway, they're happy to drink it, but not happy to have it in their skin. The last natural outbreak of smallpox was in the United States in 1949, so even before I was born, but not long before I was born, to be honest. And in 1980, the WHO declared that smallpox had been eradicated. So what's a vaccine? So what happens when we have an infection is we produce antibodies in response. Now, antibodies are little proteins which jump onto the agent that is infecting, whether it's a virus or a bacteria, and destroy it. A vaccine is designed to produce antibodies to a specific serious infection. So something we haven't met before, but would make us really sick if we did get it. That's what a vaccine is designed to do. So there are different kinds of vaccines. The first vaccines were made from inactivated bacteria, inactivated viruses. And there are various different kinds, but the two that have been used in the COVID-19 outbreak are the more modern vaccines, which are recent inventions, which are the mRNA vaccines and the viral vector vaccines. None of the others are involved in COVID-19. By the way, I will do a Word document tomorrow probably, and if not tomorrow, Tuesday, with the various links to websites that I've got on these slides, and I will send it to Zandra and she can send it to all of you or put it on the website or whatever seems most appropriate. So why would we vaccinate people? In particular, why would we vaccinate people against COVID? People are 17 times more likely to die from COVID than from seasonal flu. In New Zealand, about 500 people die every year from influenza. So we might expect that if COVID became endemic in New Zealand, about 8,500 people would die from COVID every year. Experts are now predicting that the global pandemic is going to last between 3 and 5 years. And I think I must have been in one of my visionary moods when I put new strains are a major hazard on this slide at the beginning of July, because now we know just how much of a hazard the new strains are, particularly the Delta variant, which has now arrived on our shores. And there will be others. So what about the impact of COVID-19 on people with disability? There is evidence that people with disability are more likely to die. Oh, there's a typo there. They're more likely to die from COVID-19 than their non-disabled peers. Sorry about that. There's some data from the UK from January to November last year, and I looked at the website today and they still haven't updated it with more recent data. But in that period, when you will remember that COVID-19 was raging in the UK, there were just over 50,000 people died from COVID-19. Looking at their statistics, they discovered that of those, 30,000 had some degree of disability. And over 15,000 had severe disability, particularly severe intellectual disability. So that's 3 out of every 10 people who died in the UK had a severe disability. And I think that's really quite worrying. So what about Down syndrome? So I did a search on Google Scholar, COVID-19 infection and Down syndrome, and you get about over 100,000 results. And I don't pretend to have looked at all the papers, but summarizing what is there, people with Down syndrome who get COVID are generally younger, than the rest of younger than the older age group, which we saw initially, because a lot of these papers were written or research was done in the last 18 months before the current Delta outbreak. They tend to be younger and they tend to be sicker. One thing which interested me was there was one report of only 2 cases, but noted that both of those people had hypothyroidism. So one thing I would just say, and you might like to make a note of this, if your young person has not had their thyroid function checked in the last year to 2 years, you might actually want to go and get that checked. I have no idea whether the hypothyroidism was a contributing factor for these cases, but obviously you want people to be as well as they possibly can. There was a group in Oxford who estimated a 4-fold increased risk for COVID-19 hospitalisation and a 10-fold increased risk for COVID-19 related death in people with Down syndrome. Now that's really quite striking, so and quite worrying. Right. So I'm now going to talk a bit about the vaccination program. So which vaccine are we using? I think we all know that. We're using the Pfizer-BioNTech vaccine. Now it has some other names. It's also known as Pfizer BNT162b2. And if you've been vaccinated and you've got your little card, she said, pulling her little card out and trying to show it to the, it actually says that's exactly what you've had. It's also known as Comirnaty, and sometimes it's mostly just called the Pfizer vaccine. So they're all the same thing. Now, the active ingredient in this vaccine is that modified messenger RNA, modRNA, which encodes the viral spike protein. So if you think back to that picture of the coronaviruses with all those little spikes on, that's the bit that you are going to produce antibodies to when you have the immunization. It's in a little lipid, a little fatty envelope, and it has some salt solution to keep it at the correct acidity level. It has no preservatives, and it has no mercury or any of those other chemicals that people worry about being added to vaccines. The other thing I just comment on is that a number of the vaccines have more than one name, and there are other vaccines, and it may be that New Zealand will start using other vaccines, but we haven't heard about that yet, although one other vaccine has been approved. I think it's the Moderna vaccine. So what are the side effects of the vaccine? Well, the common side effects are some pain or swelling or redness at the injection site, or if you're really unlucky like me, you get a bruise at the injection site. I was really a bit brassed off about that. Never had a bruise with my flu vaccine before, but anyway, they were processing a lot of people at the time. Feeling a bit tired or fatigued. Some people say they have a headache, muscle aches, joint pains. Some people have a fever. In terms of uncommon side effects, in the clinical trials, less than 1 in 100 people reported side effects such as feeling unwell and itching at the injection site. I would have thought they'd be quite common, but there's a lot of information on side effects, and I'll give you that link so you can look them up. Is it safe? Yes, it is safe. This might not mean much to you out of Auckland, but it's safer than crossing an Auckland road, although at the moment it's really safe crossing Auckland roads because there aren't very many cars, which is, I think, wonderful. And millions and millions of people have now received this vaccine worldwide, and it has been shown to be really safe. So where to get vaccine? This is for the northern region. And I left it in. I thought about changing it, but I left it in because if you may notice that the Auckland Central Vaccination Centre that I highlighted was the one at Elliott Rooms in the level 4 of the Atrium building, which is the one next door to the Grand Millennium Hotel, where it is thought that the current outbreak may have originated. Does it work? Yes, it does work. So this is something from the US. Now, some analysis of the data from May, so that's a few months ago now, showed that breakthrough infections in fully vaccinated people, so that's people who've had 2 doses, accounted for fewer than 1,200 of more than 850,000 of COVID-19 hospitalizations. So that's just the people who were severely unwell enough to get hospitalized. And so they had 150 hospitalized in May. And today we have, I think it's 36 people in hospital. So the numbers are just mind-blowing. So that's about 0.1% of the hospitalizations were in people who were fully vaccinated. So it's not 100%, but it's pretty good. The next question is, does it work against the Delta strain? And the answer is yes, but not as well as it did against the previous strain. And I found this paper today and I was quite touched to see the name Jamie, you may not be able to read that, Jamie Lopez Bernal as the lead author. Now, Jamie, I remember when Jamie was born. He is the son of somebody I used to flat with in the UK. She's an obstetrician and her husband was an academic, Spanish and doesn't eat onions. It doesn't quite compute to me, but anyway. He was one of the lead authors in this. So after 1 dose of Pfizer, there was less immunity to the Delta variant, only 30%. So that's people like me who've only had 1 vaccine, only 30% against the Delta variant, compared with the Alpha variant where it was about 50%. Once you've had 2 doses of the Pfizer vaccine, you are still better protected than you are still better protected against the Alpha variant, 93.7%, 94% effectively, compared with the Delta variant at 88%. So it's not quite as effective. However, it's still pretty effective. It does show the importance of having that follow-up dose to get the maximum effectiveness. Okay, I'm now going to switch gear and talk a little bit about consent. How are we going for time? Okay, so everyone who receives the COVID vaccine will need to have given informed consent, or someone else will need to give informed consent for them. So what does giving informed consent mean? It means firstly that you are provided with the information that is relevant and given in a way that you understand. You can ask questions and expect honest answers that you can understand. You will be treated with respect and you can say no. You can refuse to have the vaccine. There's no signature required. You don't have to sign a piece of paper saying I agree to this, because it's not an experimental procedure and it's not a research project. However, the recommendation from the Ministry of Health is that everyone who is eligible for vaccination receives the vaccine to protect them and their families. The issues about consent become more complex for people who have a disability. And as you all well know, people with disability range from people who are able to understand all the pros and cons of vaccination to those who are completely unable to understand. So if your family member with Down syndrome won't understand the information about the vaccine, what can you do? You can assist them with supported decision making, or you can give consent on their behalf. So if there is a welfare guardian order in place, the welfare guardian can provide consent. However, we know that many adults who have severe disability don't have a welfare guardian order in place, because those of you who have been through this process will know it's not an easy process to go to, and it involves cost. Because COVID-19 vaccination is deemed best practice, if no one else can consent, a health professional may consent on the person's behalf. But I would think for anybody who has involved family, that would not happen. It's really important that the way that consent is obtained is documented. So it's recorded how it's done. Now, these are some slides that I got from Ray Finch, who works at Spectrum, is the Chief Operating Officer at Spectrum Care Trust in Auckland. So I'm not going to read this slide in detail, but basically there are 3 different situations around how much people understand, and using the supported decision framework and social stories for those first 3. However, for a person who can't make an informed choice by themselves, even with supported decision making, then you go to the next phase, which is this one. The welfare guardian can make a decision. If there is no welfare guardian, then it's important, the vaccination has to be in the best interest of the person, and confirmation that reasonable steps have been taken to ensure that the views of those around the person are obtained. And that may be family, it may be the people who care for them, but it would hopefully be all that person's important people. And this is just a draft form of how it might be recorded. We'll make the slides available. So what if your family member has a reaction to the vaccine? So remember that minor reactions such as feeling a little tired are quite common. If you think there's a severe reaction, you should consult your doctor or get urgent medical help. You have to judge how severe it is, but you don't wait until the morning to ring the doctor. If you are really concerned about the person, you get immediate help. You or your doctor can make a report to CALM, which is the Centre for Adverse Reactions to Medicine. And if you go onto the CALM website, and that's the link there, there are 3 places you can click. Health professionals can and should report serious adverse reactions. There's a special one for reporting COVID-19 vaccine adverse reactions, but also, and this is I think quite new and I think really important, consumers or patients can record these things. And often the patient or the person around them actually knows more about it and they have a better idea of what actually happened. So some people say this vaccine was developed really quickly, so is it really safe? And I think it's important to realize that there's been a lot of cooperative work around the world with people working together to develop several vaccines. There's been extensive testing, and as I said before, several million people have now had the vaccine. And usually the approval processes are slow, but for this vaccine, they've run the processes in parallel rather than one after the other. So each committee actually getting the information at the same time. There's some more questions. I think it's now clear there will be enough vaccine. The on-time question is tricky. We are dependent on when it's delivered. And this last one, which I actually highlighted before I saw the news tonight, that everyone, including non-residents and overstayers, will get the vaccine. Everyone over 12 now. Unfortunately, there's been apparently an incident in the Bay of Plenty where people have been told they have to show their passports. And of course, for overstayers, that's a problem. The safety of the vaccine in children aged 6 months and older is currently being evaluated in trials overseas. So my daughter or son is scared of needles, but I really want them to have the vaccine. What can I do? Well, you can talk to Geraldine, and she's going to talk in a moment. There are lots of resources out there to help explain the process. You can write a social story or you can offer a reward. And this reward is what you get if you have the standard vaccination. And this is my son's hand as he walks down the steps on the railway of the bridge over the railway at Middlemore Hospital. taking a photo. Now, I thought that was stupidly risky behavior, especially for a young professional, but we won't go there. Just some last words from the UK. So the JCBI is the Joint Committee on Vaccines and Immunisation. And they pointed out that for young people at between 12 and 15 who have some underlying health conditions, put them at severe risk of severe COVID-19, should be offered 2 doses of the Pfizer vaccine, because they're using the AstraZeneca vaccine as well. And they have, I've highlighted there, they include Down syndrome in that. Very last words before Geraldine talks. The virus can't mutate, change to a new strain if it's not in a human or animal host. And as long as there are people with active infection anywhere in the world, we are not safe until everyone is safe. And it is likely, but we don't know yet, that there will be some kind of annual booster. And that may involve, like with the flu vaccine, that it's tweaked to be more suitable for new strains. And I just did like this haiku, which I ran across on the Radio New Zealand website. So I might stop sharing there and hand over to Geraldine to talk about, if I can find my mute, to talk about how to help people who want to have the vaccine but are scared of having a needle.
I haven't got any fancy slides, I'm afraid, folks.
All right.
I'm just going to chat. We've had quite a few people at the hospital where I work ask us and outside of work, and it's really every way for every person is individual. But the first thing I'd say to you is that if you've got a family member or someone you care for that has Down syndrome and they're fearful of the needles, is contact the vaccine centres as soon as possible. And they are more than happy to support you, to change their processes. Already, we've had some in the local areas I know where they've planned for the person to come. They've had special music playing. They've had one particular client I work with, mum and the young lady had their vaccines together. They were both in the car and they came out and they just, you know, worked with that person. I think they must have spent about 45 minutes with this young person, talking with them. They put Emla cream on. They asked them about their hobbies. They let them see mum having it done. They even had someone else that who let them see it being done. But it's really getting to know who the people are that are going to give the vaccine, work with them, go before for a visit. You know, don't go straight up for the day of the vaccine. See if you can pop along first and walk through. If you're going to be doing the walk-through one, walk through the building to see what's going to happen at each day so there's no surprises. Or if it's a drive-through, just see if you can go at some time and see what the process is. And yes, definitely use social stories, use the resources that are available on the ministry line, health line, and just be prepared to go more than once. I know here at the Mid Central Health, we're looking at quite a few different options at the moment so that we can support the people with disability in more low stimulus areas, trying to find environments that are more friendly, more accessible, and working with staff that we actually do some additional training with some staff before they go, so they've got more insight into what may be needed for someone, but realising that everyone's going to be different. That's me, really.
Thanks, Geraldine. Shall we move to the questions?
Yes, absolutely. And thanks so much, people, for putting your questions in the chat function. If you want your question to be anonymous, you can send it to me privately. And we can do it that way. One of the themes coming through in the questions pretty clearly is there's a concern that people with Down syndrome might be prone to specific side effects or more likely to get side effects, particularly because of some of those comorbidities like heart and respiratory issues. You guys got any comments on that?
Marguerite, do you want to take that one?
Yep, so I saw that coming my way. I think the simple answer really is to go back to kind of first principles, which we often do when we're looking at immunisations, and to look at our children with Down syndrome have been having all their other routine vaccinations, and to the best of my knowledge, they have not had any extra or untoward or excessive reactions to any of their other routine vaccinations. So that I would not expect that they would be in a specific group that would have any more reactions than anybody else. One of the
people who asked the question raised that her child had had a previous adverse reaction.
Yes,
you had a previous, would that increase it?
To a certain extent, we actually, it depends what the previous reaction was, to be honest. If it was an anaphylactic reaction, which would be a very severe reaction, then the answer to that would be yes. If it's like a severe reaction in terms of a very high temperature, lots of muscle aches, maybe even a little bit of a rash, then the chances are probably not. To be honest, we often say that actually a reaction to a vaccine is really good because it actually shows that your body is working, your immune system is working and producing a response to the vaccine. So if you don't get a reaction, sometimes you wonder whether you did you have anything?
Could I just add something in there, Marguerite? For people in that situation, do you think there is an option for them to talk maybe with their GP, because a lot of the GP practices are now giving immunizations, and perhaps having the vaccine given in the GP clinic with a more intensive observation period?
Absolutely, I think exactly. I think if you've got any concerns, I think the important thing is to customize, as Geraldine said, to customize your young person's vaccination event. And sure, if you have got issues like that, talking to the GP's practice first and getting some reassurance, possibly even getting the GPs to discuss with pediatricians as well. I know that one of our colleagues at Starship runs a special immunisation clinic in the past. I'm sure, again, they would be available for advice, as would, of course, the Immunisation Advisory Centre.
Thank you so much. I'm going to read the whole next question verbatim because it's a good one. My son with Down syndrome is 6 years old, so at this stage he can't receive the COVID-19 vaccine. His father and I will receive the vaccination, but the vaccine could make us asymptomatic if we become infected with the virus and can give it to our son. How can we control this?
Shall I take that one? I'll make a start. That's a difficult one and obviously pretty scary for that family because at the moment, our knowledge of how readily people who are vaccinated, who have an asymptomatic infection, can transmit the virus to other people is really pretty sketchy. It's certainly a theoretical possibility. You may be aware that the worker in Warkworth, north of Auckland, who has been diagnosed with COVID-19 was a fully vaccinated person. I don't know whether that person was symptomatic. It doesn't seem like she has passed it on to anyone else in the dementia unit where she worked, which is a great relief for everybody. I think if we get back to level 1 and there is no transmission in the community, I think that's pretty safe. But I think limiting for an unimmunized, an unvaccinated child who is vulnerable, I think you are going to want to be careful about social contact. So you're going to want to be really clear that people who have upper respiratory symptoms, even if they've been vaccinated, should stay away from your child. And I don't know that there's an easy answer. I'd be interested to know what Marguerite thinks about that.
I agree, Rosie. I think that's a very, very tricky situation. Like you said, you want to be very wary, certainly, of other people around your unvaccinated children. At home, you are in your home bubble and you have been in your home bubble. Obviously, if you're well, you're well. If you're unwell, again, obviously you pass over the care to somebody else. Hopefully you have got somebody else to pass that care over to. Asymptomatic, as Rosie said, we don't know. I think you're just going to have to use those really good first principles of coughing in your elbows, washing your hands, and teaching really good personal hygiene. I don't know if Geraldine's got any comments, Geraldine?
No, I was about to say about just universal precautions. Yeah, coughing into the elbow, washing the hands, just minimising the risk as much as possible.
Thank you so much. There's been a couple of questions around the gap between vaccines. So the New Zealand recommendation at the moment is 6 weeks, but other countries are saying to stretch it out to 8 to 10 weeks and that's more effective, possibly particularly if you have underlying heart issues. Do you guys have any comments on that?
Marguerite, do you want to go on that?
Yeah, sure. Our original interval, as you know, was in fact 3 weeks. And that was because that was what the data and all the trials were on. Subsequent data suggesting that pushing it out further may give you longer lasting immunity, but obviously you've really got to look at what's the situation you're in. Do you want to get as many people vaccinated as quickly as you can? As Rosie points out, you've got a degree of immunity from the first one, but much, much better when you've had 2. So do you want to get 2 of them in close so that everybody's got really good immunity? Or are you in a situation where you can afford to push it out slightly? So it's, at the end of the day, it becomes kind of a compromise almost as to what works best for the situation at the time. So as long as it's greater than 3 weeks, slightly longer is probably better. So that's why we've landed on 6 weeks at the moment. Again, that may, for some people, may well depend, vary because of supply and demand, because of availability of vaccination centres, getting their appointments. So some people might aim for a 6 week timing and they might end up with 8. They might end up with even longer. Yeah. Does that make sense?
I deliberately went for 8 weeks, so I'm booked in for my second one on the 21st of September. However, given the data on the much lower protection against the Delta variant that we now have, I'm thinking, oh, did I make the right decision, especially after a trip to Pack and Save last Friday, which was absolutely, social distancing was just not there. So I think, as Marguerite says, it does depend on context. And certainly if you can keep your person safe from places like Pack and Save, that's probably a really good idea.
Yeah, and if you can, then go for longer. But if you can't, then as long as it's greater than 3 weeks, you're going to get that immunity.
Yeah.
Thank you. There's a question about the newly introduced 12 to 16-year-old age gap who are going to become eligible, and that's only been the case around the world for a relatively brief period of time. Have enough kind of 12 to 16-year-olds been vaccinated? Are we comfortable that that's just as safe as people over that age group, given that it's been happening for a shorter period of time?
Marguerite, do you want to go?
Okay, I don't mind. I was going to take a leaf out of your book, Rosie. I really like sometimes when people ask Rosie tricky questions, she just goes, yes. Like, I've considered this and the answer is yes. I think there's enough data throughout the world and across trials for us to be, and again, going back to first principles and vaccinology, for us to be happy to use it in this age group. Yes.
I think the other issue is that the death rate from this disease is appalling. And so one of the challenging questions is, which is the worst evil? Vaccination with something which is probably okay, but might cause a little problem, or waiting to get the wild disease and possibly ending up in intensive care or worse. So I think it's really difficult.
Yeah, once again, Rosie's put it in better words than I was just about to say. The other thing is that, yeah, you know, we know that COVID-19 can be extremely rampant in this young group, especially in the new variant. So what's worse, getting COVID-19 or the vaccine, which is to date is proving very safe?
Yeah.
Thank you. There's a question of, if a child has no other medical issues other than Down syndrome, are they still more at risk? My memory of that Oxford study was that it had been controlled for comorbidities, but I'm definitely not the expert here, so I'll pass back over.
Marguerite, have you looked at the Oxford study in detail?
I haven't looked at the Oxford study in detail, no, but again, from first principles, anybody with Down syndrome is at slightly increased risk of infections.
How long have RNA vaccinations been in use?
Oh, Marguerite's on mute. That looks so it's not long at all. This is a new technology. So the answer is not long. But we do have the experience of the last 18 months and a lot of hard work. There isn't any reason to suppose these vaccines wouldn't be reasonably safe. I have read something about the issue of this vaccine, or all of the vaccines, I think, are aimed at the spike protein, because that is the protein that is essential for the virus to actually infect the respiratory tract. And there has been some suggestion that maybe we need a vaccine that is perhaps put into the nose so that it acts at the site where the virus first arrives. So I think there will be further developments. Marguerite, do you want to go on that?
Yeah, the reason I went mute was I was trying to find out an exact time for you. RNA vaccines, as you say, are newer vaccines, but they have been around for a reasonable length of time. And what you have to remember is that previous vaccines have taken a much longer to develop than this one, because of taking longer doing the studies in isolation instead of working together. And so, in fact, they have been around for, yeah, not as long as Edward Jenner, but long enough for us to be very happy that they're safe.
Awesome. Just another kind of follow up on some of the side effects. The question's about if someone's had adverse reactions in the past to the flu vaccine, whether this should be part of the decision whether or not to get them vaccinated for COVID, and not quite related to that, but also our children with asthma and allergies. I'm not sure what kind of allergies, but is that something to factor into that decision as well?
I think, again, if you're concerned, as Rosie is suggesting, you need to discuss your individual young person with the person, or the medical person who knows them best, which hopefully is your GP. And again, draw on experience from their previous vaccinations. Again, it depends what sort of adverse reactions they've had. It's a caution, but it wouldn't be a contraindication.
Fantastic. Just a couple more questions. I know we're sort of getting towards the end of the time, but if you do have any more questions, pop them in the chat. If you have to head off because it's nearly 8:30 and you have another Zoom to get to, then do feel free to do that, as say this will be recorded. But if it's okay with our experts, if we hang around for another 5 minutes or so just to deal with those last couple of questions. So this is an interesting one. If you're currently breastfeeding, and I'm going to add into this also if you're currently pregnant and get the vaccination, will this protection be passed along to the baby? And I don't have any news, by the way, don't anyone get the wrong idea. I know that when you're pregnant and you get the flu vaccine, that's the reason. That's the only reason I'm saying that.
So if you're breastfeeding, and I'll let Marguerite chip in as well. So the maximum time that immunity passes from the baby, from the mother to the baby, is in the 3rd trimester of pregnancy. So in those last 12 weeks of pregnancy, immunity that the mother has to conditions like measles and German measles and all sorts of conditions actually goes to the baby. Once the baby is born, the baby gets some antibody in the initial breast milk, and breastfeeding has a protective effect against infections, but I would not expect a breastfeeding mother who is immunized to be passing that immunity to her baby as a result of breastfeeding.
And another question we've got here is, there's been talk about booster vaccines or a 3rd dose to improve protection. Do you know about the evidence for this?
There won't be evidence until people have tried it. But as you know, that's been discussed in relation to the very, very small number. I mean, I think the fact that there are something like 20 people involved in these query they didn't get enough vaccine discussion, when we have actually given, I think it's 3 million doses now in New Zealand. And we've got about 20 people where they may have received an inadequate dose. And one of the strategies that is being considered is that those people may be offered a 3rd dose, particularly if we don't know whether they have or haven't had the wrong dose. Does that make sense? But I think that will be an emerging area, and I think we can expect that there will be research going on in other countries where they have many more problems. I'm actually just going to share my screen again because I've got a slide up which might interest you. So I'm just sharing, I'll share it very briefly. So this is from today's data in something called the Worldometer. And I just want to point out that there are 8 countries which have had more total cases than the total population of New Zealand. And there they are: the USA with nearly 40 million cases, India, 33 million, Brazil, Russia, France, the UK, Turkey, and Argentina. So I think that kind of, and if you look at the death rates, the total deaths in those countries are figures that really we find absolutely amazing, stunning, very disappointing. And I said this at the previous talk. If everybody had done what New Zealand did last March, then we wouldn't be in the mess with the Delta variant that we are now. And I particularly blame the leaders of the UK and the then leader of the United States, who thought they were such clever blokes. I'll shut up.
On that topic, just a follow-up question. Family overseas have informed me that they're being told they will be having the 3rd booster vaccine, but they can't have the same one again. Why is this?
Don't know. I suggest they go back to whoever told them. Have you got a comment, Rosie? That's something I've not heard of before.
This is an overseas family, and so we don't know which vaccine, and we don't know why they've been told.
Right.
they can't have it. And it may be a supply problem because there is not an unlimited supply. And a little plug for the guys who run the pandemic quiz, that if you register with the pandemic quiz, but you have to be prepared for some bad language, you pay a registration fee, which is $30 to participate. And they are donating vaccines to UNICEF, I think, or Oxfam.
Awesome. Someone's put in a sort of bit more of a comment, I think, but people with asthma, etc., are more likely to have serious illnesses, including COVID. So wouldn't it be more important for those individuals with asthma to get the vaccine, notwithstanding side effects? A general nodding and agreement.
Completely, totally. That's the whole point. Yes, you know, whatever side effects or adverse effects or effects that you might feel and have with and after the vaccine will undoubtedly, without any question, be much less than any effects you may have from catching the disease.
Which brings us fairly neatly onto the final question that I have here, which is our nearly 15-year-old boy is also type 1 diabetic. He had the vaccination yesterday. His bloods have spiked since. We feel this is simply his immune response, so a good thing. And just to treat with additional insulin, is that the right way forward?
I think I'll go there. We're not endocrinologists. I wouldn't dream of suggesting what they should do. I would suggest they should contact the person they usually contact when his diabetes is causing problems. So that may be his pediatrician. It may be, if it's Auckland, it may be the endocrinology team at Starship.
Fantastic. Well, that I believe is all the questions that we've had through. Zandra, do you agree with me there? Is there anybody?
Kia ora, yes, thank you. I think that those are all the questions that we've captured. I am just aware that Gretchen and I think it was Catherine had two very specific questions, and I just think it might be worthwhile once everybody leaves, if maybe they stay on and we just have a conversation with them, because their questions are more specific. So let's just talk about that, about just concerned about reactions, previous reactions. So, but other than that, I think, yes, those are all the questions done. And so thank you so much, everyone, for joining us today.
Thank you so much, Zandra, for putting this together. Thanks so much to our three experts. Very, very comprehensive, reassuring. Yeah, just fantastic. So thank you very much. There's about 800 million thank yous coming through the chat box if you can't see that.
Yeah, I think we've all found it so extremely valuable. So thank you, Rosemary and Marguerite and Geraldine, for spending this time with us. And thank you, everyone, for joining us today. Enjoy the rest of your week.
Thank you all for being such a lovely audience.
Thank you.
I didn't have to go near my remove button. You were all brilliant.
Thank you. Take care all. Hope to see you somewhere this week on some other Zoom.
See you on Tuesday.
Yes. So Catherine and Gretchen, if you just stay on board. I think, Jean, did you have a specific question you wanted to just clarify? I saw your question. Maybe you just want to stay and we can just answer that one too, Jean. Okay, so that's us. Thank you. I just thought that your question.
Should I stop the recording before we get?
I think so. Yes. Thank you, everyone.